Pediatric cardiologist. I work at Indiana University School of Medicine. I run a basic lab. I run a clinical research unit as well. And I founded Chondrial Therapeutics to push therapeutic forward for this disease. So I've known this disease since 2003 when I originally talked with Ron Bartek, and FARA was early in its genesis. I guess we kind of watched each other grow old together.
I'm still growing up, Mark. I don't know.
So I'm not peaked either, so I'm looking forward to that day when they don't card me at the store. So I've known this disease for a long time. So by way of saying that introduction, can you tell us who you are and we'll just go around the room?
I'm actually just a general public.
Okay.
I came across with this website about online events incidentally, and I saw this event, and I'm generally just health conscious.
Okay.
And never heard about this symptom of disease before.
Oh, very good.
So I'm curious. I just want to learn something about it.
You're welcome.
Thank you.
Hopefully you'll spread the word to others.
Yeah.
I'm Tatiana Russo. I'm her younger sister. She was
Okay.
diagnosed like 2 months ago. And just here for support to learn what I can
Is
do.
she a good big sister?
Sometimes.
And you must be mom.
I am mom, and Bianca went undiagnosed for many years. So she's 26 now, but the symptoms were showing from when she was 8, 9 years
Oh,
old.
really? What were the symptoms?
Clumsiness, like falling quite a bit.
Okay.
Yeah, and shakiness.
And has she been a fairly rambunctious normal kid up to that point?
Yes.
Okay.
Yeah. But it's just progressed in the last couple of years.
Okay.
Definitely within the last year, it's
All right.
gotten to a point. So.
Oh, my name is Dan O'Connor. I'm from Scottsdale, Arizona. My girlfriend's oldest son was diagnosed with ataxia in high school, and we've been together for a while now. And so I just came out with her. We had a wedding out here, so we thought we'd come here. They wanted to come to the seminar, see all this, and pick up as many bits of information as we can.
Okay. Please.
They did it for me. It's okay.
Erin, I'm friends with Brenda.
Retta, I'm 62, and I go to a cardiologist every 2 years. I'm an echo every 2 years, but I just went last time in November. He said, "Oh, you're doing symptoms you've been doing for 10 years, and just come back in 2 years. We'll do an echo." So I'm wondering why.
Okay. Maybe we can talk about that. Hi.
Hi, my name is Caroline Hopkins. This is my daughter Grace, my husband Tom.
Okay.
Grace was diagnosed when she was 13 with FA.
Okay.
And it took us a little while to get the right diagnosis. We went to a neurologist at first who just said it was something else. And then I just felt in the pit of my stomach it wasn't that, it was something else. Until she got the genetic test, that's when we found out.
Okay. And it's okay.
I thought it was going to fill out more. Eric, I'm 33. I was diagnosed at 17. Yeah.
Okay. So it's an interesting point that y'all bring
You can
up.
sit next to me, Eric. I won't bite, I promise.
She doesn't, she's nice.
Most of the time.
How often, Jen, have you run across the patients when they're diagnosed after a long time, even though they may have had symptoms for a while? Does that happen a lot?
So we just looked at the patient registry data
Yeah.
and the data from the natural history study. And the average time to diagnosis is 4 years. For individuals who have their first symptom younger, so around 10 years of age, the average is 2 years. But then for individuals who are having their first symptom around 17, it's 4. And for individuals who are 25 and older, it's 8 years.
How come the delay?
I think there's a lot of reasons why the diagnosis gets delayed.
Yes?
I think in the young kids, it's the classic onset of symptoms. It's pretty textbook.
Yeah.
And so it's more recognizable to the pediatric neurologist, and it's more acute. The symptoms are changing faster,
Yeah.
whereas in the later onset, the progression's more slow, and so you're not seeing changes rapid over time, and the differential diagnosis from a neurologic perspective is much longer, so that diagnostic odyssey kind of gets dragged out.
Interesting choice of words, odyssey is right. And there's a difference in the GA repeat numbers that's important.
Yeah, so for individuals who have later onset, 25 years or older, those, at least one of the two repeats is usually shorter, like 200 repeats, for example, and then somebody who might be onset around age 17, their repeats might be around 500, and then individuals who are closer to age 10, the repeats tend to be like 800 or 1,000. So there is a difference usually. It's not perfect, that's just a range. There are exceptions to those rules, but in general, yeah.
Okay. So in the last group, I kind of started it off with a discussion of scoliosis in the heart, and I'd be happy to talk on that in a minute, but I also talked about the rhythm disturbances that crop up, monitoring of the heart over time, what should you be doing. So from a cardiologist, again, I've been studying this since 2003, and there's some really unique things about the FA heart that make it different than any other cardiomyopathy that I follow. And in pediatric cardiology, most of what we see is structural abnormalities in the heart. So they have holes, or plumbing goes to the wrong place. And that's interesting to work with. It's very challenging. But the cardiomyopathies that we see tend to be contractile protein defects. That ain't what this disease is. This disease is a mitochondrial defect, and it has a very unusual impact on the heart. That being said, almost all cardiologists today are trained to look at contractile protein defects that make the heart thick. And hypertrophic cardiomyopathy is actually pretty common, and it's also pretty fatal for certain types of it. But that's not the FA heart. The FA heart has a unique hypertrophic cardiomyopathy. That means it's very thick wall. And the reason it gets thick wall is because the mitochondria inside the heart cells proliferate out of reason. And if you do an electron micrograph, instead of having neat little rows of mitochondria that make energy for the cardiomyocytes, you've just got this football field of mitochondria that just expanded. So the cardiomyocytes get very thick. And then when they die, which they will do, the space that they occupied is filled in with fibrous tissue. So over time, the hearts get really thick. Their pumping action remains quite good when you look at it. But they get really thick and they develop kind of a fixed, it's almost a concrete-like behavior because they won't expand to accept more blood. So when your heart has to fill with blood, and it does that during the resting phase of the heartbeat called diastole. And when it beats, it's called systole. Well, the ability to beat is what you feel in your neck whenever the heart beats. That's systole. And that, most of the time in Friedreich's, is preserved until very, very late in the heart disease. But what gets compromised very early is the diastole, the ability of the heart to relax and accept blood. That becomes important because we have great drugs to make the heart beat harder. We have got no drugs that make the heart relax. We've got no drugs that make the heart get rid of fibrous tissue to any great degree. There are some. They all have their own side effects. I have seen dramatic improvement on a few patients with Friedreich's where I put them on some of these medicines. Again, they have side effects, which are lowering your blood pressure, which most of the Friedreich's patients tend to run low blood pressure anyway. So if you lower it more, you just feel out of gas. And that's a common complaint. So the hearts are very thick. That becomes important when you do certain things to people like stressful surgery. Well, today the stressful surgery for Friedreich's is scoliosis surgery. So they get a curvature in their spine that they have to go to surgery to get fixed. And during the surgery, the surgeon typically will lower the blood pressure so they don't lose so much blood because it's a big, kind of bloody surgery. And they typically cut out the glucose from their IV because they don't want a sticky field to work in. And the anesthesiologist up here It's responding to all of this by saying, well, I'm going to give lots of fluid to maintain good cardiac output. The problem with all of that is when the hearts get thick and they get heavy fibrous tissue inside of it, giving a lot of fluid means there'll be fluid overload, and it usually puts them in the ICU and puts them at risk of doing poorly. Doing poorly, I mean they die. And I've had plenty of phone calls about that from patients who went into the surgery and they got too much fluid. The other thing that matters is whether or not they have fuel, glucose, in their IV fluids. Because the heart burns fatty acids most of the time. It will burn glucose when they don't have good fatty acids. So when we eat a hamburger or a pizza, lots of fatty acids, the heart's just chewing it up, loves it. Fats carry a lot of food, carry a lot of energy. Glucose, on the other hand, is what we all have in the morning when we wake up and we haven't eaten all night. Glucose keeps things going. But if the heart can't burn fatty acids because the mitochondria don't work, and they're not getting adequate glucose in their IV infusion, then the heart will run out of gas, and cardiomyocytes begin to die, and they do very poorly. You get into kind of a spiral where it's hard to get their heart function back up, and they do poorly. So one of the things that we did early on, and one of the other FA parents did this, and she did this by talking to a bunch of us, was put out recommendations. And the recommendations for the scoliosis surgeon was, don't drop their blood pressure, don't take glucose out of their IV fluid, keep it in there, put up with a sticky field, and don't give them too much fluid. And again, these are based on best judgment. They're not based on any statistical clinical trials. But since we've done that, I have not gotten another phone call from a parent or an ICU doc saying this child is dying because subscoliosis surgery went poorly. And it's one of the things that I feel good about because we were able to make a recommendation that seems to have had an impact, a positive impact on scoliosis surgery, which is a big deal even for a patient who doesn't have heart disease. But it seems to have had a very positive impact. And so the thing that we advocate today is for a scoliosis surgeon, the orthopedic surgeon or the neurosurgeon, whichever's doing it, talks to the cardiologist who becomes more involved, and talks to the ICU doc and the anesthesiologist. So everybody is talking about this heart because it does no good if scoliosis surgery was great, but the patients die because their heart disease was unable to be addressed at the time or anticipated. So I think that it has had a significant impact. Again, the most that we can do with that is put out our best judgment clinical recommendation, and we can do that, and we can update it as well. But we can't back that up with clinical data, by way of saying, here's the data. We can back it up with basic science data, and we've got that.
Mark, you have a question?
Yeah.
If the FA person doesn't have cardiomyopathy, how careful do they need to be?
I think they always need to be careful. I think they always have the cardiomyopathy, even though they may not have physical findings on echo. That being said, we talked a bit about this. What I've seen, at least in my practice, is that the cardiomyopathy breaks down into two camps, those with really thick hearts and those who don't have thick hearts, and they look pretty normal. I treat both of them with respect, but the thick hearts I treat with far greater respect. And if I see a thick heart and it has been leaking enzymes from the heart that tell me the heart is being damaged chronically, then my recommendations are a much higher level of suspicion of injury and anxiety for the orthopedic surgeon. The hearts that are thick, normal walled, and their function is fine and their ability to relax diastole is normal, I've found that they don't leak cardiac troponins, and they typically are very normal in their behavior. I typically get much less problems with arrhythmias out of those hearts compared to the really thick ones. So if their heart looks normal on echo and they're 15, 20 years of age, probably they're going to be normal for a long time. That's not to say that I turn my back on them. I echo them every year. I do an Holter on them every year. I do an EKG on them every year. But I don't turn my back on them. But if they had, something go on, yeah, I'd be happy to talk to the ER doc, but my anxiety levels are a lot lower with them than it is with somebody who's got a thick heart.
Yeah, and the FA doctor, the FA patients who get scoliosis surgery, Grace didn't need it, but they could be unfamiliar with the process that you just described. But on the FA parents group, I know because everybody sort of fishes for it every once in a while when their child comes time for surgery to come up with a list, it's printout of instructions for.
Is that still on the FA? Is that?
It's circulating,
It is.
yeah. Somebody always asks for it
I have
periodically.
it printed out.
Yeah, so that's very
Yeah.
helpful, and the thing that it really makes people do is make your doctors talk to each other. I mean, as doctors, we hate that. We're supposed to love talking with each other and collaborate, but the reality of life today in a busy practice is nobody can do that. But this is a point where the FA parents need to advocate for their child, no matter how old they are. Don't assume that the orthopedic surgeon is going to pay attention to those recommendations. Don't assume that the ICU doc has talked with the anesthesiologist. So the anesthesiologist doesn't run in 4 or 5 liters of fluid, because that will put them in the ICU and that will hurt them. And so
So it's also just for any
communication.
surgery, right? Not just for, it's for any surgery.
It's for any surgery, but scoliosis is particularly bad
Yeah.
because it involves a lot of fluid changes in the body.
Okay.
And that's the one that really is harmful. If they had an appendectomy or a cholecystectomy, taking the gallbladder out, that's not that big a deal. The scoliosis surgery is a biggie,
Okay, because they have to cut down the spine.
and it's very stressful on the body.
Okay.
A couple of questions on HCM, Doc. What are the symptoms? We'll start with that. What are the symptoms of HCM?
That's a good question. Typically, there are none. They are not symptomatic in terms of, let me back that up. The FA patients cannot run and exercise like a normal person who has hypertrophic cardiomyopathy from a contractile protein defect. And I don't want to get really technical on this. Those patients who have contractile protein defects, they run and play like everybody else. And they only notice that they had that because they either developed a murmur or because they fainted because their cardiomyopathy caused them arrhythmia. The patients who have Friedreich's hypertrophic cardiomyopathy will frequently not have any symptoms, with the exception of this, and this is one of the things we talked about last session. With the hypertrophes, they get atrial arrhythmias, so they get SVT, which as a pediatric cardiologist we see this day in and day out in normal kids. So supraventricular tachycardia, their heart rates run anywhere from 180 to 220 or 260. You can't count it. And the patients will tell you right away, man, there's something wrong with me. Mom, what's wrong? You can't count it. As opposed to somebody who's scared or anxious, they'll be running 150 beats a minute, and you can count that. The other problem they get into is atrial arrhythmias from AFib, atrial fibrillation, and atrial flutter. Those are particularly bad because it puts them at risk of stroke. And that goes for any of us in the room. If we get AFib or a flutter, we're at risk for strokes, and that's really bad. Number two, if you lose your atrial rhythm, you lose about 10 to 15% of your cardiac output. Well, if the ventricles are already compromised because they're too thick and they can't relax to accept more blood, if you lose the atrial kick, they're going to notice that right away. They will be out of energy, they will have no ability to stand up because they get low blood pressure and they'll pass out. They will tell you right away, there's something wrong with my heart and I don't feel right. It's easy to pick up. It is easy to pick up in the emergency room or in your doctor's office because we can do an EKG right away. We can do a Holter monitor overnight. We can put on an event recorder for the entire month and pick it up. Sometimes atrial fibrillation and flutter is episodic. It happened today, it's gone off. So you can see the doctor and everything checks out. But if you put them on an event monitor, which is something they just wear for a month, yeah, you'll pick it up, absolutely. We can treat this. We can treat SVT. We can treat atrial fib and atrial flutter. It's not that it's easy, but yes, we can treat it with medicine, or we can treat it in the cath lab by burning out the bad electrical signal. Or we can put in a pacemaker, for example, to override the atrial flutter. We can treat it and keep people out of trouble. We can treat that. The bigger problem to treat has been the thickness of the heart muscle itself. we don't really have good drugs to treat that. And it becomes important because, again, the heart can't relax and accept a new charge of blood, diastole. It's got a fixed ability to accept blood. And so that's led to a bit of controversy for how you treat that. I personally use specific drugs, angiotensin receptor blockers, which have been shown to help with the fibrosis. And I've had a few patients really respond in a big way to that. But those also lower your blood pressure, and most people don't like running low blood pressure. And FA patients tend to run low, number one. The other drug that gets put onto FA patients quite frequently because of the thick heart has been a drug called beta blockers. If they tolerate it, great. That actually comes from the adult literature from adults who have heart attacks. It's been shown if you put them on beta blockers, their cardiac function actually goes up. It gets better over time. And it's ostensibly because they burn less oxygen and damaged heart syndrome. The problem with the FA hearts, and I've seen this in some of them, is that the beta blockers slow down their heart rate. But if their heart has a fixed ability to accept blood and then pump again, and they lose that ability to increase their heart rate, they feel bad. So sometimes we have to use the drugs called beta blockers because of arrhythmias. And if that's the case, so be it. That's what we have to use, and we'll work out a way to get around that. But at other times, we don't have to use those, and there are other medicines that we can adjust. This becomes, we've not been able to do a clinical trial with that. I think it would be great if we could, but we just don't have adequate patient numbers to do that with. And what we would be using as a readout, the clinical trial endpoint, would be a bit difficult. That being said, for this, we really do have to use best clinical judgment for what medicines to put the patients on. And some of them are not on any medicines, and that's fantastic.
Is there a connection, doctor, do you know, between repeat and repeats and the severity or onset of the HCM?
I think the repeat numbers, and Jim can correct me on this, the higher the repeat numbers, the worse the heart disease. That being said, the heart disease doesn't track with the repeat numbers. So I've seen, and you can fix me on this, but I've seen lots of 800s, and they basically have neurologic compromise, always. But their heart's not affected, at least not on their echo. And that's been something I've been agitating to get at for many years, and I haven't gotten anybody right on it because it goes into an area that I don't do in my lab. Some guy in Oklahoma does, but he won't go after it. But that's a very interesting question about why the heart, if you see two patients with 800 repeats, or 700 in their short allele, and one of them has bad heart disease and the other doesn't, they both will have neurologic compromise. But for the life of me, I can't understand why the heart and one of them doesn't have that problem.
How about for a carrier? The repeats in a carrier manifested with HCM in some way, perhaps?
If I saw HCM in a carrier, I'd look for a contractile defect, which is a completely different disease. I would not look for repeaters, unless they had a point mutation in the other allele, for example. Yes, ma'am.
So this might be a little specific to me, so I
Okay.
apologize. But I'm one of those FA patients with the 800 and a normal heart.
Yeah.
I was wondering if you had any suggestions on, like, they told me to, what was it, COQ10?
CoQ10?
There we go. Are there other things like that you'd recommend for us to help?
So, yeah, none of these have been shown to have a clinically recognizable positive endpoint.
Okay.
That being said, when I see FA patients in my clinic and they're on these medicines, I never tell them to take it all, because that's what they have faith in.
Right.
And that's all we have. I think in the long run, the things that will make a difference in this heart disease and this brain disease is getting frataxin back into the cell in some form or fashion. I don't care how it gets in. I just want to write a prescription for it. But I don't recommend CoQ10 or idebenone or 743 or fish oil. Fish oil is good. Don't like that. But, Right. That being said, none of these have been shown to have an effect that has a lifelong effect.
Okay.
Debenone, for example, over a year's time was shown to thin out the walls of some of the hypertrophic cardiomyopathies in the NIH trial. That may be important in the long run, but we can't run the 10-year trial that it takes to show that. So if you're on this and you're happy with it, don't stop. If it's a huge expense to you and you need funds to drive something else, yeah, you can probably stop it and you're not going to suffer for it. Good question. Yes, ma'am.
Other than finding a new cardiologist, she just went to see, he did the test, she wore a monitor for 2 days, for 48 hours.
Okay.
Came back and said that everything looked good, but he knows nothing. He's not heard of Friedrich's. He knows nothing about it, but come back in a year for a checkup.
Yep.
So is there something that Bianca as a patient can say to either this doctor or in looking for another doctor? Like, are there doctors who specialize or?
There aren't many, which is why Mark's from Indiana and he's in California.
That's what Sue Perlman was saying this morning. She said, geez, why couldn't I call somebody at UCLA? And I started to say, well, maybe they might have UCLA. And you bring up a really good point, and it's one that Jennifer has really been kicking me for, and she's right, because I haven't written the paper, because I really don't have any data on it, which is best management practice. I think that if you're seeing a pediatric cardiologist, they are much more attuned to congenital or inherited heart disease than an adult cardiologist is. That being said, and this is really, really important, and patients will travel to see you, and then they go home, and they don't have a good cardiologist, or they don't have a cardiologist that they can depend on. And I'm stuck trying to manage somebody 500 miles away. So my advice is this: get a cardiologist that you have faith in and trust in, and this person will listen to you. Because at some point, if they call me, or they call Kim Lynn at Chalk, for example, we need somebody that we can talk to back at the home base and say, well, our experience with this kind of hypertrophic cardiomyopathy is beta blockers aren't well tolerated, but you can try them on losartan, for example. That reduces the hypertrophy over time slowly, or aldosterone. Or, yeah, this arrhythmia needs to be addressed maybe by radiofrequency ablation or put them on medicine for it. You need a cardiologist that you can talk to back at the home base. So if you trust this person, fantastic. If you don't trust this person, my advice would be to get another cardiologist. A lot of the pediatric cardiologists are pretty comfortable with cardiomyopathies that occur because of an inherited condition. That being said, you've got to go with what's in your health plan and who's nearby, because you can't be driving 500 miles. The other thing that comes up is, I hate to say this, but if somebody has a problem, they're always welcome to contact me. And Paul Conance has been wonderful as an initial contact person, and he will usually get in touch with me, and I can follow up on that. If you're sending me direct emails, I can be slow to get back, but I'm always happy to work back through one of the cardiologists locally, or if one of your kids winds up in the ICU or in the hospital. I'm happy to talk with them about that. I talk with ER docs, because they have no idea what just came in the door. And sometimes the FA patients may do normal 25-year-old things that make them wind up in the emergency, like had a good time Saturday night. And so they come in with a really fast heart rate, and the ER doc may not treat them like a FA patient, but may treat them like a normal 25-year-old who got drunk and came in. And that requires a different thought process. So I'm happy to talk with those guys.
Yeah, somebody go over here, Mark.
I have another question. My daughter's in the same category as you are. And so she's been seeing a cardiologist every year. The cardiologist has changed, the location stayed the same. But nobody's ever done a Holter on her. And I just heard you mention that.
I do a
So I'd
Holter.
like a little
I do.
So she should be getting that as well, and you mentioned you had it.
Well, here's the thing about Holter exams. If you want to cure an arrhythmia, put a Holter on a patient. They will never have another arrhythmia. If you want to catch a bad rhythm, we use what's called an event monitor. So it's 3 or 4 wires stuck on them, and they wear it for a month. And those, that's okay. I mean, they take it off when they take a shower.
Okay.
It's a little box they wear on their side.
Okay.
And if they're having arrhythmias, it automatically calls up on the phone and sends this information in. We see it, hey, you got AFib, we got to call in. But they at least need a Holter once a year.
That's what I meant,
Yeah.
Hold to once a year.
And that's my recommendation. There were other questions?
If it's okay, I'm sorry. I could ask so many. But, I guess it's just patient to patient. It's an individualized situation where, like, will she definitely have heart problems in the
Can't answer
future?
that.
Or,
Can't
yeah.
answer that. What does her heart look like now?
They
They
told me
said
it was
good.
fine. They said they have palpitations sometimes.
Well, so here's the other thing that I talked about in the last group, which is all young people have anxiety attacks that range from really mild, get out of my office, to full-blown panic attack, and you have to treat that. And it's rare that they get to this far. That being said, as I told the last group, I never ever turn my back on a Friedreich's patient because they can do something, even though their heart looks normal. The problems that I've had out of normal-looking hearts that beat fine with Friedreich's and their walls are thin, nice and thin, they're minimal. The guys who I have a lot of trouble with are the ones who have thick hearts and they beat fine, but they don't relax fine. Those guys have a lot of trouble. Those are the ones that I follow on more frequent basis.
Mark,
Yeah.
there have been some people in the past who've had some sort of like secondary event, like not just surgery, but like an infection.
Yeah.
And that seems to kind of kick in or precipitate changes in the heart.
Like arrhythmias?
Yeah, or even just it'll all of a sudden advance. The cardiomyopathy will be stable,
Yeah.
and then they end up with an infection, and then all of a sudden something
So,
changes.
a couple of thoughts. First was what Sue Perlman listed last on her slide, which is take care of yourself. Just because you got Friedreich's doesn't mean you won't get the flu. The flu will kill you because you have a compromised ability to breathe. So that's an infection. Get a flu shot. Don't be dumb. Get a flu shot. They make us get them in a hospital just to work there. So get a flu shot. It's not 100% effective, but whatever preventive measure you can take, get it. The second thing that you ask about is the one that has bothered me in cardiology ever since I started doing this, which is I think a lot of us get subclinical myocarditis when we get viral syndromes, like a head cold, because we all notice we're having funny rhythms in our heart while we're sick. I've thought about these patients, and I'm really curious as to whether or not they get a subclinical myocarditis, viral infection in the heart, but in them it isn't tolerated because they have a very compromised cardiac function. I think that's part of it. That being said, if you get pneumonia, bacterial pneumonia, that's a huge stress on the body. It really is. But I really think that some of the patients can get viral myocarditis that manifests as a head cold. That's what you see. But they actually do have an infection in their heart. I think that's real. There's very little that we can do to test for it.
Okay.
But I think that can progress rapidly. Yeah. That's a hard question to answer. I've not seen that in the Friedreich's patients, but I've seen that in other people.
We've had a few.
I think myocarditis in this
CHOP.
population would just not
Over
be
the
tolerated
years.
at
Yeah,
all.
it's not well tolerated.
Even if they have a normal-looking heart. Yeah.
I have a question. I've got clothes. I've got it. Well, I have had it. And I was 28. I did have rods put in, but he put them on. They were called C rods.
Okay.
And because the small one at the bottom, so I could bend, but I was still working it done. And with Walker, and they ended up pulling out
Yeah.
So I had to get everything removed, and I was totally straight for like, I had them in for 2 years, and I got bad atrophy. And my urologist at the times, I asked him, will it go back to, bending, curving? And he said, well, yes and no. When you break your leg, you fix the leg and walk on it, and it doesn't break you. But in your case, the muscles will pull it back. That's why I'm turning now, my hips, turning my leg. So I'm wondering, can they redo surgery at my age?
I don't know. That's it would be misleading for me to answer that because it's outside my field. My answer to that would be, you need to see an orthopedic surgeon who you trust and say, my back problems are now causing me hip problems. And
I'm going to a physiatrist.
Yeah.
And I have a referral. I saw him before, and he knows how he did my, when I referred me to someone to.
So this is a really complicated question that takes somebody who is experienced in the field in terms of, and you're going to find these kind of people at large medical centers, and that might be where you go already.
Yeah.
But you're going to need a couple of opinions from some very experienced surgeons regarding that. I say that by way of saying surgeons were made to cut, and they're always going to cut if you ask them, should you cut? And it may mean that you need to see a neurologist also who supports that approach. Because the neurologist may have a different approach that will help you. You understand what I'm saying? This is a complex question, and you need several opinions on how to approach it. But you've got a long way to go, and you want to be as comfortable as possible. I understand it's hard to find somebody and get them to see them, but yes.
Well, I'm from Canada.
Where?
I'm from Canada.
Oh, yeah.
They'll have kids.
Different setup up there.
Totally different.
I totally understand.
I'm really convinced somebody to.
Well, all I can say is here in the States, I'd recommend that you get to see at least 2 orthopedic surgeons for different opinions, but I understand DC has got different healthcare structure.
The guy actually did it the first time. He moved to San Francisco.
There you go.
That's what I was going to recommend.
So we covered rhythm problems.
Yeah, Mark, you got like 5 tops,
What?
5 minutes.
Oh, we covered rhythm disturbance. Again, SVT, atrial fib, atrial flutter, that's what we see in these guys. We can fix that, we just need to know that it's going on. And most of the time, your kids are going to tell you, this feels weird, what's wrong? The thick hearts, those are the ones that I get anxious about. The thinner hearts, it's not that they're free of disease, they have disease, but they don't cause the problems that the thick hearts do.
Troponin. We didn't cover
I
troponin
didn't
in this
cover
one.
troponins. Oh, what do I do on my clinic visits? I see these guys yearly unless there's some big deal going on. I always check an echocardiogram, I always check a Holter, I always check an EKG, I always check cardiac troponins. Cardiac troponin I is what the heart releases whenever the heart is having a heart attack. What we've seen in these patients is that some of the thick hearts chronically release cardiac troponin. Okay, that becomes very important because that's how I track how sick the heart is. And if it's chronically leaking troponin, it means something different to me than if it's not. And that also becomes very important when your sons and daughters go to the emergency room and they're complaining of chest pain. And what young person doesn't complain of chest pain? The ER doc will check a cardiac troponin because that's what they're trained to do, and it will be elevated. And you must have medical records in hand that say, hey, this has always been elevated. They're not having a heart attack, they're having an anxiety attack. The point that I'm leading up to is get your sons and daughters' medical records together. Put it into a little chart. Make sure that your doctors are checking cardiac troponins looking for diabetes, checking echo and EKGs on these patients and Holters, so that when they do go to the emergency room, you can hand them this packet, or they can look it up online where they're normally followed. And he or she, the doctors, can say, they've always had chronic troponin leak. This is not new. This is not a heart attack. This is something that I can manage by other means, not going to the cath lab for a cardiac coronary angiogram. Did I cover the topic? Yes, okay. So, other questions or thoughts? Thank you very much.
Thank
I'm happy to have
Thank you.